All right, now if first degree AV blocks were a delay and second degree AV blocks were more like a detour, third degree AV blocks are a full shutdown. Let's look at that. Okay, so third degree heart blocks are also known as a complete heart block, and that really gives you an indication as to what's going to be happening at the AV node. Nada, nothing. The SA node is still firing, it's still sending signals to the AV node, but the AV node is definitely not passing on the message to the ventricles. So we have a complete blockage here. Now the ventricles, remember we have those backup generators. So the atrial will still be under the control of the SA node. It will still fire at rates between 60 to 100 under normal conditions, obviously responsive to the environment. So if I'm sleeping, it may go lower. If I'm exercising, it will go higher. And the ventricles will be under the control of either of the other two backup generators. So our AV node has that intrinsic firing rate of 40 to 60. It might be sending the signal. It might be creating the signal. It's not sending the signal that it got from the SA node. Or it's under the control of the Purkinje fibers, and they have that intrinsic firing rate of 15 to 40. The most commonly known cause is congenital disorders, and this happens in infants at a rate of 1 in 22,000 births, where they end up having a much higher mortality rate as a result of these congenital conditions. And an example here is neonatal lupus, which is passed on by the mother. Now, there are other causes that can also create a third degree heart block. And here we have some of the same things we've seen in previous heart blocks. So this is why we mentioned in the first degree that even though it's pretty benign in terms of its signs and symptoms, it doesn't cause a lot of distress for the patient. It can advance into a more serious arrhythmia. So when we look at these common causes, coronary artery disease, anterior, inferior MI, those were certainly highlighted in the first and second degree heart blocks. Degenerative changes, digoxin toxicity, our calcium channel and beta blockers. So anytime our patients are on these treatments for pathology of the heart, we need to be monitoring and following up for arrhythmias. Now, when we look at it on the screen, it almost looks like a sinus brady. I can see P waves, I can see QRS waves. They look a little wider than usual, but that's because there's something special happening there. We're going to dissect that as well. So here's our saying, if P's and Q's don't agree, then you have a third degree. Now I've highlighted the 3 QRS waves here, so that's a rate of 30 for these ventricles. But the other thing to note here is the P waves. So you'll see that they're actually buried inside the QRS wave. Whoops, there we go. They're actually buried inside the QRS waves, and so they would march out. Now that's a term we've talked about before in level 1 ECG interpretation, that marching out phenomenon, in that you can predict when the next wave will hit. It's regular. So my P wave, P wave, P wave, P wave, P wave, P wave. It's predictable. I can find where it is. And if I can't see it, that's because this little notch here, that's the P wave buried inside the QRS. It can also be buried inside a T wave where you may not see the P as well. When we compare this to all the parameters, the details that we should be finding in our analysis, we will find that the atrial rate is regular, and the atrial rhythm is regular, and the ventricular rhythm is regular. The atrial rate will be greater than the ventricle rate. The atrial rate can be anything, normal, sinus node is in charge, and the ventricle rate will be usually less than 60. It can be faster. We'll talk about junctional rhythms in the next module. Now the P wave will be round and upright because the SA node is in charge of the atrial contraction. That's not where the problem is. The problem is with that darn AV node, it's not passing on the message, nada. And so you may also find that those P waves are buried. They're missing. Again, that's one of the hallmarks here, is that if you can't see it, it's likely buried. The PR interval will be inconsistent. You won't be able to map out anything. I mean, at first glance, this looks like it might be a block because that's a really long PR interval. and then I don't have any. So geez, is this like a second degree where we've dropped a QRS? This one looks shorter, and then I'm missing. This one looks normal. That's why we have to do our analysis. Inconsistent. We can't find any sort of pattern in this ECG tracing for the PR interval. That is a hallmark feature. QRS is narrow if it is junctional, meaning that the junction is in charge of creating the QRS impulse, or wide if it's ventricle. Greater than 0.12 would be ventricle. So if we were to measure this QRS, it is wide. So these would be the ventricles that are actually the Purkinje fibers that are in charge of this rate, and that is why I have such a slow ventricle rate. QT may be prolonged if you can see the T wave. It's absent in this rhythm, so you need to correct it. Let's compare that to our normal sinus rhythm, shall we? When you look at these two, what should stand out first of all is the ventricle rate is really slow in the second strip. And the second thing that should stand out is that there's a bunch of P waves with no QRS complexes. And then the third thing that should stand out is that the PR interval, we can't make any heads or tails out of it. That's your clues. So if your P's and Q's don't agree, then you have a third degree. When we compare this to the first degree, remember the first degree has a normal, predictable, consistent PR interval that is prolonged greater than 0.20 seconds. Also has a one-to-one conduction, one P wave, one QRS. In comparison, again, PR interval inconsistent, and there is no relationship to the QRS. Now let's take a look at Mr. and Mrs. Jones. What's happening in that relationship? Well, Mrs. Jones she just grew tired of sitting at home. No more. She's just carried on with life doing her own thing, and the husband is doing his own thing, and they both have very regular schedules, but neither of those two schedules line up. They don't coordinate with each other. So the wife is no longer waiting at home. She and her husband are now both on separate but regular schedules and have no relationship with each other. Now, this is generally going to create symptomatic patients. As you can tell from those rhythms, there's not a lot of ventricular contraction to support the cardiac output. So we're going to pace them. Atropine, consider epi and dopamine. We need to initiate IV therapy, get them oxygen, and we want to minimize those activities that are going to just increase the oxygen demand. When we have inconsistent patterns, we don't know how much fluid's actually in the ventricles when it contracts, so we have no idea what the cardiac output is for these patients. So those symptoms of decreased cardiac output become important predictors. In the next section, we're going to look at pacemakers.